Welcome to Brain Wellness, the podcast. I'm your host, Mandi NP. What started as all things related to brain health and wellness has morphed into largely brain injury health and wellness, with occasional other neurological topics. My mission remains the same, to help you on the path to a healthier brain. So, without further ado, let's get into the show. Hello, everyone, and welcome back to another episode of Brain Wellness, the podcast. Today, I am by myself, and we are here in 2026, the first episode of 2026. You guys, this is really exciting. So this show has been around since 2022, end of 2022. I started it back in October of that year. And we have had so many amazing conversations on this show. If you're just tuning in now, where have you been all my life? But in all reality, if you're just tuning in now, please do go back because we've had some amazing episodes on this show since October of 2022 when we first started this. But here we are in 2026. This is crazy to me. I don't know where 2025 went, but we've covered a lot of really good topics, as I talked about last week on the show when we did the year-end wrap-up, going through just kind of the highlights of what we did in 2025. And it was really fun and really exciting to go through all those. So I hope you enjoyed that episode as well. Today, I'm back with the next installment of the ABCs of concussion. And if you're watching this on video, you see I've got a little attachment here. I just had rotator cuff surgery last week. So, I'm in the whole recovery phase from that, in addition to still trying to get my brain to do its normal thing after my brain injury. So we have a lot of things to talk about today that may or may not be experienced by somebody who has a brain injury. So again, when I'm doing this whole episode, the series on the ABCs of concussion, every single one of these episodes is meant to highlight the things that are related to that letter or letters for that particular week that may or may not be something that somebody experiences with a brain injury. So if you are the person that had the brain injury and you're wondering, is this normal? Maybe these will normalize those symptoms for you a little bit. If you are the caregiver or family member of somebody that has a brain injury and wondering what's going on with them, maybe some of these things will answer those questions for you. And if you're the provider in a clinic or in a hospital setting, hopefully these will help you identify that these things also are related to a brain injury, and you do need to address them with your patients. So many different reasons for having this conversation. Wherever you are in that spectrum of needs, hopefully we can find something that will help you out here today. So today I'm combining the letters N and O because neither one of them really had enough to cover an episode by themselves. So we'll do a few topics on N and a few topics on O that, again, are related to brain injury. The first one being nausea. So nausea is actually a very common symptom after a concussion or head injury, and it's often accompanied by some sort of balance disruption. So if somebody's balance is off, that's typically going to cause a lot of nausea. Think about if you've ever experienced motion sickness. If things are moving around you, if you're sensing things moving around you, it makes you nauseous. You get that same kind of feeling. It can be with or without true vertigo, but that nausea is definitely there, oftentimes related to that balance disruption or with vision also. Nausea can happen right away. So some people will experience it immediately after having that injury that caused their concussion. Or sometimes it develops over the next days to weeks, or it can develop later on, depending on what the cause is that's giving them the nausea. It can be triggered by things like light, noise, activity. Again, all of those visual cues, the sensory cues that can overwhelm a brain that's trying to heal and cause that nausea sensation. Again, causes of it. Brainstem irritation. So if the brainstem is involved in the injury, especially if there's any kind of rotational force at the time of the injury, that can cause that nausea to occur. Inner ear dysfunction, if we have small fractures inside those little teeny bones in our inner ear, or we have a tear, a dehisced canal, all of those things can happen after a brain injury. All of those can lead to dizziness, headaches, nausea with them as well. And then autonomic nervous system dysfunction. And this is one I see quite frequently. So you'll probably hear me talk about that autonomic nervous system more and more on the show because I really do think it's very important and it's often overlooked. So inner ear dysfunction, if we're looking at that particular cause, again, related to vestibular dysfunction. So the auditory and vestibular nerves are so close together in there, and both of them can be irritated with an injury from something that caused a concussion. So that can be accompanied, again, by the vertigo or the dizziness. And Think of it like if you've never had vertigo, and God bless you if you've never had vertigo, it feels like that spinning sensation if you're on an amusement park ride, and right after you get off, you still kind of feel like you're spinning. Somebody with vertigo feels that on a continual basis at times. So that can definitely cause that nausea to come on. This may be associated with, again, visual processing difficulties, because if you're not seeing things correctly, if you've got double vision, that makes that whole motion sensitivity even greater. And it's often triggered by things like riding as a passenger in a vehicle. If somebody else is driving, when you're driving, you have something to focus on. When you're the passenger, you get to look out the window, and that may or may not be a good thing if you're experiencing this nausea sensation. Being in busy places like grocery stores or shopping malls, just that busy environment can trigger that nausea. Navigating crowds, and then that positional things, quick bending or turning movements of the head or the torso, or rolling over or sitting up in bed, which can cause the dizziness, which causes the associated nausea. With the autonomic nervous system dysfunction, it can be related to multiple things within that disruption. It can be related to disrupted digestion, alterations in the breathing patterns, which can increase the carbon dioxide concentration in your blood, which leads to nausea. It can be lightheadedness related to blood pressure or heart rate changes. That can also cause the dizziness and then the nausea that goes along with it. And then, kind of separate from that, is your gut microbiome. So we all tend to forget about this whole gut-brain connection, but that's been covered on this show multiple times as well in the past. When we talk about this gut-brain connection, there is this whole microbiome within our gut system that helps to break down our foods. Those bacteria are good bacteria, and they are helpful in breaking down the foods and turning things into the nutrients that we need inside of our body. When we have antibiotics in our system, we have all these other things that it kills that microbiome. We have stress in our system, it kills that microbiome. So we don't have our normal processing for breaking down foods. So when that microbiome is messed up, given that explanation I just gave you, you can probably assume that that can lead to some nausea as well. A single episode of nausea with or without vomiting is not something that we usually correlate with a poor outcome after a brain injury. It can happen. It's very common. People have that one episode. We don't worry about it too much. What we do worry about is if you have worsening nausea. That worsening nausea, the vomiting starts to come on, especially if it's accompanied by a worsening headache. Maybe you have one dilated pupil, weakness or numbness in the face or extremities, slurred speech, bruising around the eyes, seizure, loss of consciousness. Any of those would be a red flag for us that something bigger is going on, such as a head bleed, a skull fracture. That needs immediate attention that you need to go in for right away. So if you're experiencing that, that's something that we do not pass go, do not collect the $200, go straight to the emergency room and get evaluated to make sure that we're not dealing with a bleed or a skull fracture type of situation that's going to need a higher level of care. How do we treat nausea? There are some simple but not easy techniques, and then there are some more advanced techniques that we need to think about. So some of the simple ones would be resting. We always use rest as kind of that backdrop. Avoiding the triggers. If you can identify what's causing the nausea for you, try to avoid that if at all possible. Eating smaller meals, because the larger meals tends to cause a little bit more nausea. So smaller meals more frequently. Getting adequate hydration, that's often a big trigger as well. If you get even a little bit dehydrated, that can cause some of that nausea to kick in. With your nutrition, we talk about this a lot again too, but avoiding processed foods, including probiotics and prebiotics in your diet. So those fermented foods, the Greek yogurts, things like that, that can help replace some of that flora, that gut microbiome, and help things move along a little bit better. Things like ginger or peppermint. So ginger candies, ginger oil, ginger gums, chews, any of those things, ginger teas, any of those things can help to decrease some of that nausea. Peppermint also can do a similar thing. So using a peppermint oil, a peppermint tea, peppermint candies, things like that can decrease that nausea sensation also. Light physical exercise can be very helpful just to maintain health. And then sometimes we use prescription medications like antiemetics, Zofran, Compazine, things like that, or antihistamines, even Benadryl. Hydroxyzine can be very, very helpful for alleviating these symptoms, but they don't treat the underlying cause. They treat the symptom themselves. I have had a couple of patients that have come through and they get this severe sense of that motion sickness, in which case we've talked about C-bands. So it sounds like a really simple thing, but we have acupressure points on our wrist. Can't point because I can't lift my other arm. And we have acupressure points on our wrist that can help to decrease that nausea and motion sensation. So I've had a couple patients that they don't do well with the prescription medications. And we try those C bands, those pressure point bands. It's like a cloth wrap with a hard plastic pressure point that pushes on your wrist. Those can be significantly helpful for that motion sensitivity type of sensation when you feel like things are moving, you feel like you're a passenger in a car or you are the passenger in the car. Wearing those bands can help to decrease that. I used to use those all the time for motion sickness when I was flying on boats, anything. It helps for this post-concussion nausea as well. So that's kind of the quick and dirty on nausea after head injury. The next topic I want to talk about is neurofeedback. And this is not something new to the show. We've talked about it a lot. And I looked back and I really have had it on this show a lot. So episode 9, Melissa Hergert came on. She is the kind of lead person with Brain Core centers around the United States. It is a neurofeedback organization. So they each have their own little, almost like a franchise, but they all get the same training and they all use the same database, the same technology. And it's a great, great technology. From that episode 96, I had Minsan Sowers, local here to Minnesota, using the Brain Core technology to talk more about that neurofeedback and what we can do as far as like brain injury types of things. After that, episode 100, I had Dr. Andrew Hill on, kind of taking an even deeper dive. He's like the grandfather of neurofeedback and brain mapping. So we did a lot of really in-depth conversation on what the purpose of the neurofeedback is, what we do with brain mapping, all of that. So that was a really, really cool episode. So any of those 3 would be good to go back and look at and listen to if you want to get more about the neurofeedback. Just kind of quick and dirty summarizing of that. Using neurofeedback to correct that electrical dysfunction following a brain injury has been a very, very effective way to treat multiple symptoms that people experience from their brain injury, including headaches, mood changes, concentration difficulties. And this, again, is not putting a Band-Aid on it. It's actually fixing those electrical current disruptions. So when we do this, we start off by mapping the brain. So we get this quantitative EEG that looks at your alpha, beta, theta, and your delta waves and figures out what's going on. Each of those waves should be active in different parts of your brain at different times. So when we're trying to think of whether you've got your eyes open or your eyes closed, your different brain waves should be doing different things at different times in there. So it maps out what your brain is doing in all of the areas of the brain, all of those different brain waves. Are they doing what they're supposed to be doing, or are they not what they're supposed to be doing? And then when we find that area of disbalance, maybe we've got a unilateral mismatch. One side of the brain is much more hyperactive or hypoactive than the other. And that's what we look for, is that hyperactivity, that hypoactivity, and something that we can change on that to refunction, make your brain work the way it's supposed to again. We do have to be careful because we don't want to train away good things. So if you are somebody that's really focused on things, you've always been really focused, we don't want to train that away, because that's helping you to do your job and do your life successfully. We want to train away the things that are making difficulties for you. So after a brain injury, it's really common to see kind of a decrease in beta waves throughout the brain. Those beta waves allow us to be able to concentrate and focus. So when we can boost those beta waves, we can make you more able to focus, more able to think, to concentrate. So we retrain that to get those brain waves acting where they're supposed to be. This is not something you can do by any kind of manual training and purposely training your brain to do this. It's something your brain has to do. So that's why this neurofeedback works really well. And then we remap following the treatment to see, what have we done? Have we actually? And I did 2 rounds of neurofeedback after my brain injury. That second round, I had like a 40% improvement in brain function. So it was amazing to see my brain doing what it was supposed to be doing. And my function in life has been significantly different since that time. So very, very useful. It is not intended to be that single magical treatment that fixes everything. We often use this as an adjunct to other treatments. So when I did this, I didn't stop doing my OT speech therapies. I still worked with them. And I saw better improvements because I was doing this retraining of my brain. What it does is kind of leverages this idea of neuroplasticity that we've talked about on the show, that we are all aware of with brain injuries in general, is this idea of neuroplasticity, that ability to recreate connections in the brain. Our brain is not ever static. It's not changing. It's always in a changing mode. And when we're healing, when we're learning new things, we're constantly regenerating cells and recreating connections in the brain. And using neurofeedback leverages that so that we can use that neuroplasticity in a good way to get those skills back again. And then this is one of those few things that we can actually target those specific areas of the brain because we identify what's going wrong, and the treatment is based on that area. So the leads go in that area to try to treat it. And another benefit of this one, it's a drug-free treatment. So there really aren't a lot of side effects other than just kind of feeling better afterwards. So we don't have to worry about that. We don't have to worry about interactions with other medications that patients are taking because it doesn't really matter to that extent, but we can see a lot of good benefits. Again, we've covered it pretty well in depth on previous episodes, so go back and listen to one of those 3, 9, 96, 100, all of these different ways to figure out how best to use neurofeedback in your recovery. The next topic is neuropsychological testing or neuropsychiatric testing, whatever you want to call it. Traditional neuropsych testing is done by a neuropsychologist, and it takes typically 3 to 4 hours of testing. So it's a very intense day. Sometimes people will break it up and do multiple sessions rather than one big session for patients. Sometimes it's just nicer to get it done all at once. So total of 3 to 4 hours, and it measures cognitive functions, things like memory, attention, problem solving, language skills, visual spatial skills, processing speed, executive functions like planning and organizing, emotional regulation, and then your executive functions again. So looking at all of those different functions in the brain, lots of different ways to test it. It is intended to help guide your rehab process. So it helps to determine your capacity to return to work or school, or maybe you're not quite ready, or maybe this is showing that you might not be ever ready to go back to that same kind of thing that you were doing before. It does include multiple different testing techniques. So there's some interviewing with the patient. So the neuropsychologist spends time talking with the patient initially, getting that history, the background, figuring out what's going on, what the problems are for the patient. There are some questionnaires, depression questionnaires, trying to figure out, is it a depression type of thing? Is it not depression? And then a series of standardized testing methods with both physical and mental tasks. So sometimes you're having to move things with your hands or draw things or from memory, from looking at things. Using blocks to rearrange things, and then doing some computerized testing with words and auditory testing, listening to stories and reading back the information. And I can tell you that because I've done it twice after my own brain injury to find out the areas that I had some deficiencies after my own brain injury. There are some drawbacks to this neuropsych testing, though. So when we look at that, it's kind of poor real world validity. You're doing this test in a provider's office, which is a very quiet environment. There are no distractions. There's not kids running around. There's not machines beeping like there would be in your workplace. So it's a very quiet, very regulated environment. But it's really kind of hard to extrapolate that out to the real world a little bit because at no point in life are we in that really quiet environment where we don't have distractions going on. I don't know about you, but I've got 3 teenagers at home. My work life is really busy, so there's never a time when I'm quiet, not even in the bathroom because the dogs usually come in with me. So, there are some challenges with effort and motivation at times on these exams, this assessment, and then there's a really long wait time. So this is a big barrier to getting this test done right now. Some places are looking at 8 to 9 months or more before you can even get an appointment scheduled. So that is a long, long wait time to get those in. And other difficulties that we have from that is that it may not accurately reflect those higher level cognitive functions. When we're looking at somebody who's really high functioning at baseline, maybe they have a graduate degree or higher, or they are working in a really high brain function task, you're not really testing a lot of that on the skills that we test on the neuropsych testing. So you might have somebody that pre-injury might have scored well above average on all these things, but now is average. So it's not really showing a deficit because you're average. And for many people, that's fine to be in that average category, and that's where they are. But if you're not used to being in that average category, that is a deficit for you. So that's my big takeaway from those tests, is that it doesn't really take into account what your baseline would have been had you been able to get a good baseline before injury. I wish we could have baseline neuropsych evals on everybody, because then if something happens, we know what their baseline was. But we don't have those baselines. So then when we're looking at comparisons, it's, well, yeah, you're in average range. You're just fine. Your brain is functioning just fine. This is where the average person sits. But if you're not in that average functioning at baseline, we do need to take into account that is a deficit for some of those patients that come in. And then retesting. If you retest too frequently on this in-person test, it can skew the responses because it's the same booklet that you test out of every time. The tests are exactly the same every time. So whether or not you intend to, some of it, your brain will start to remember the things that you were tested on. So that skews those results a little bit. So you might get slightly higher scores than you normally would because you've tested on this thing so many times now. So you always also have to be careful with that. There are some alternatives to this traditional test, and one of them is one that I'm now implementing in my clinic, Creos. Creos is an online neuropsychological assessment that tests 12 different functional domains, very similar to that traditional neuropsychological test. And again, having gone through the traditional neuropsychological test and having taken the Creos test myself, I can tell you there's a lot of similarities. So it's a really good representation of what's going on that neuropsychological functioning status based on this online test. And it is not an independent diagnostic tool. So you can't get a diagnosis code or something based on this and say, yes, you have this, or yes, don't have this. But it can be a tool to, as an adjunct with all of the other assessments that we do to say, yes, based on your other findings, this correlates with all of those things. And this definitely shows that you have some areas of limitation. And it only takes 45 minutes. So it's not a 3 to 4 hour test, it's a 45-minute test. And the retesting skew is less likely because it's computer based. So while you're testing the same topic, the same idea every time, it's done in a slightly different way. It gives you different questions to test it the same way, different visual things to test it the same way. So it's not going to be the same test every time, but it's testing the same things every time. If that makes sense. So I have really loved and enjoyed using it in my clinic on the patients that I've tested because it really helps to identify the areas that they are struggling with. And if they score really low, maybe that is somebody that down the road we are going to want to do the full neuropsychological test so we can see really what everything looks like. But it's a really, really good screening tool to figure out, do we need to do the full neuropsychological test? Can this help give us some ideas on what to work on with speech therapy, with occupational therapy in the meantime, to really work on some of those areas of struggle so that the person can become more efficient in life? So there's that. The next N topic, which I believe is my last N topic, because I didn't have a ton of this one, quite, there's one more after this, is neurogenic bladder. And this is one that, as I've been reviewing my information, I'm getting ready to take my CBIS exam, the Certified Brain Injury Specialist. That is one of the topics that I've been reviewing on there again, is neurogenic bladder. And neurogenic bladder occurs when the nerve signaling between the brain and the bladder is disrupted. So somewhere in there, that nerve signal is disrupted. It can lead to things like poor bladder control and either incontinence or retention of urine or just incomplete emptying of urine when someone is trying to go to the bathroom. It puts a person at increase for UTIs or kidney infections or skin breakdown, anything related to that because of the incontinence issues or the retention issues. And it can lead to some social isolation and decreased quality of life for the individual because, again, if they're have this incontinence issue, they're not going to want to go out in public. They're not going to want to go get together with people because that is a very embarrassing aspect of that recovery. So it does lead to a lot of social isolation for these individuals. What does it look like? What are some of the symptoms that you might see with this? Urgency, needing to go to the bathroom right away. So you went from not feeling like you have to go to, I got to go now. Frequency, having to go very frequently, whereas you wouldn't think you'd need to go quite that frequently. Having leakage when you don't want to. So losing some control of that urine. If your bladder is over full and you didn't realize it was too full and it starts to spill over. Difficulty starting a urine stream or difficulty emptying your bladder completely. And then loss of sensation at times. So some people will just not have any sensation. They don't know when their bladder is full. And that can lead to incontinence because their bladder gets full. It can hold no more. And then it has to release. There are several different types of dysfunction that we can see with this. The first one is overactive, also known as spastic or hyperreflexive bladder. This is where the bladder contracts involuntarily. And that leads to that urgency and the leakage issues because that bladder contracts and tells you, you got to go now. You can't wait. You have to get there immediately. The next type is an underactive, also known as a flaccid or hypotonic bladder. That bladder just doesn't contract very well. So it fills and fills and fills. You lead to retention issues, and it leads to overflow because the bladder is filling. You don't get that sensation that it's full. It can't contract. You can't completely empty the bladder, and then you get that overflow issue. And then sometimes we have a mixed. We have a combination of the overactivity and the underactivity together, and we would have symptoms of both of those then. How do we manage neurogenic bladder? Often we will do it through managing fluids, so trying not to give too many fluids later in the day so that we don't have issues at night. Timed voiding. So if somebody doesn't have that sensation of their bladder being full, take them to the bathroom every 2 to 3 hours to empty the bladder, or try to empty the bladder so that it doesn't have that risk of the urine just sitting there and leading to those UTIs. There are some medications that we can use to control the spasms in the bladder or improve the function. So those would be taken on a case-by-case basis. And then for some patients, again, if they're not having that sensation, timed voiding is not working, we can do a clean intermittent catheterization, or for some people, a continuous catheter in place to empty out the bladder. Botox injections can be helpful for some of those spastic bladders. Bladder retraining with physical therapy. Probably shouldn't have listed that up above because it's not going to be as invasive as some of these other treatments. And then in some severe cases, some patients do have to have surgery, such as a permanent or things like that, because of this neurogenic bladder. And then the last N topic I have is new baseline. And this one is really, really frustrating for people who are trying to recover from a brain injury. Especially when somebody's had subsequent head injuries, they've had multiple head injuries, it can be very difficult to get back to exactly how you were before the injury. Difficult or impossible at times. So oftentimes we have to create a new baseline. This is your new norm. And it's never easy to tell somebody when they're at that point. And it's really hard to tell until you're really kind of there. So you won't be able to identify that you're at that new baseline until you're there for some time. So once you've gone months and months with no improvement, you've tried all these different therapies, you're really not getting better, that's probably your new baseline. But if you're still seeing improvements in therapies, that's not your new baseline yet. You're still on the way to get there. But it can take a really long time for people to kind of get to that point where they aren't seeing a lot of significant improvements anymore. As a reminder, again, there are two main ways that our brain heals. One is by having those cells recover and take on their job fully again. They pick up and do the thing that they're supposed to do. And then the other main type of healing is compensatory. So we learn compensation strategies to do the same things that we did before, just in different ways. And these new compensatory strategies may or may not be more effective than the way we did things previously. But either way, when we go through those compensatory strategies and we're now learning different ways to do things, that new baseline may look different. Now we might have to take notes on things where we didn't have to take notes before. And I've had that conversation with many, many patients, and I have to take notes on things now where I didn't used to, but that helps me remember things. So you might have to be that person to take notes now so that you can still do your job as effectively. You might have to have more accommodations, whether it's a physical accommodation or a functional accommodation or something, quiet space, light, dark rooms, or different lighting so you don't have that fluorescent lighting above you, triggering headaches. There are lots of different things that we can do for accommodations that still makes you successful in your workplace or in your life, but it's going to look a little different than it did before. So that's where we get into that new baseline. So that's it for the letter N. If you have other things that you think I should have included, let me know. I'll try to throw them into upcoming episodes. Otherwise, I've got a few O letters for you to round out this next letter of the alphabet before we wrap up today. So the first O letter is OT, occupational therapy. And occupational therapy is a funny one because I used to work with OT all the time in the hospital with stroke patients, and I thought I knew what they did, and I didn't really realize all the things that they could do. So their main areas with occupational therapy is with our activities of daily living, also known as ADLs. That's our basic things like bathing, dressing, eating, grooming, toileting, our functional mobility, all of those things. Those are the main tasks of an occupational therapist. And they also work very closely with the instrumental ADLs, the IADLs, the meal prepping, managing finances, housekeeping, managing medications at home. And then there is some overlap with OT and speech with cognitive. And this is where I struggled before because in the hospital, I always saw the OTs doing the cognitive screening. I didn't see the speech therapist doing it. So I didn't realize how much speech therapy works on cognition as well. But this is one area where there's a little bit of overlap between speech therapy and occupational therapy is that cognitive skills. So OT can also help with things like attention, memory, organization, planning, problem solving. So planning your day, oftentimes OTs are working with patients on mapping out your day. What are all those activities look like that you're doing in a day so you can spread them out appropriately, plan them appropriately, run your schedule so that you can manage those daily activities. So it all comes back to the ADLs, but in a cognitive way. They can also work on executive functions. We've talked about executive function today a lot with the neuropsych testing and everything else. They can help with that executive functioning by trying to manage fatigue, reducing stimuli, and pacing tasks through those things like making the schedules and planning out your day. They can also help to adapt skills to return to work or school or your leisure activities. And then again, was one of my favorite things when my mom had a stroke. What the occupational therapist came in and brought a keyboard into the room because my mom was a newspaper editor. So she needed to be able to be on the computer keyboard. And that was my favorite thing that they did was bring that computer keyboard in and have my mom practice on that because that was functional. That was getting her back to what she needed to get back to work. And that was my first favorite thought of OTs in management of patient symptoms. The bigger part that I send patients off to occupational therapy for now is for vision therapy. So that includes things like tracking, visual tracking, depth perception, scanning your environment, especially when people start getting kind of that tunnel vision and when things get overstimulating. And then working on the double vision with convergence issues and accommodative exercises. So there's a lot that can be done with that's in the kind of the domain of occupational therapy. What's the frequency of occupational therapy? Usually they start off weekly and then they can go to biweekly and then monthly before they start to taper off with patients. But the length of time will vary very much between one person to another. So I can't really tell you the length of time, but the frequency is pretty consistent there. But my caveat to that is that make sure you're working with somebody who has experience with the brain injury population. Not all occupational therapists can do vision therapy. Not all occupational therapists have experience with brain injury. So the more you can get in with somebody that has experience with brain injury, the better your outcome is going to be. And then not all therapists will be a good fit with every patient. So I've had some patients that have had to switch therapists just because they didn't click very well with that person. And that is okay. We are not all meant to click with everybody. If we would, this world would look very different. But if you're not clicking with your therapist, if you don't feel like you're improving, switching a therapist can sometimes be the best thing for you. Find the different tricks, different techniques of the other person, the different style of working with patients. So it's not a bad thing. And sometimes you just need to switch that up a little bit so that you can find more effectiveness with your therapy. The next O topic then is organization. And this one can be taken a couple different ways. I'm not talking about brain injury organizations. I'm talking about the abilities of the person to be organized. So when somebody has a brain injury, it can affect your ability to maintain an organized life and living spaces. The cause of this disruption can be damage to the frontal lobe of the brain, which affects your executive functions again, the things that allow us to plan, to start and finish tasks, to prioritize, to manage multi-step activities. That's all frontal lobe executive function type of tasking. And we can also see difficulties with time management, getting easily distracted, trouble with sequencing. Some of those are executive function tasks as well. And then cognitive fatigue can lead to a lot of difficulties. So if you have some of these difficulties already and you are now cognitively fatigued, it's going to make those organizational skills even worse. Yay. So what else can make it worse? Fatigue in general. So physical fatigue, cognitive fatigue, stress, illness, too much information. So information overload, when there's too much coming at you, it's really difficult to kind of digest and organize those things. And then an overwhelming environment. If there's too much happening in the environment, doesn't matter how calmly you're trying to give the information. If there's too much in the environment, it's still going to be overstimulating for the person. And then what it might look like. So it might not always look the same in every individual. If somebody has trouble planning and initiating things, they're going to have trouble starting or finishing those tasks. They might look like they are procrastinating, putting things off. They can have difficulty planning their day or their schedule, kind of organizing what they need to do from day to day. Task management can be difficult because they get stuck on one thing and they can't move on to the next thing that they have to do. Switching tasks becomes a big chore. When you have to stop one thing and move on to another, it can be very disorganizing in itself. And then struggling with multi-step tasks. So if you have to do laundry, for example, when you do laundry, you have to wash the laundry, you have to put the laundry in the dryer, you have to fold the laundry, you have to put it away. Those are several different steps. So doing all of those steps can be very overwhelming and very disorganizing. You can do one part and then get distracted and then forget to come back into the next step. Memory and focus You can forget appointments. You can lose track of items or time or have difficulty learning new items. And then with problem solving, you can have the inability to see the consequences. So when a problem comes up, you can't triage it very well. You can't troubleshoot very well. You might make poor judgments. You might kind of rapidly think or be impulsive in your thought process. So any of that that all would be problems with organization as well. And then how do you manage it? So the first thing is structure. Create set times and places for your tasks and for your belongings. So if you are going to if you have trouble organizing where your keys are, for example, have a place to put your keys all the time. My husband struggles with this on a regular basis, and his keys are never where they're supposed to be. I hang my keys up so they're at the same spot all the time, and I know exactly where they are. I've been doing that since before my brain injury, but have a set place for things. If you have a certain task that you have to do and you struggle with it, maybe keep a notepad by where you sit on the couch or by where you sit at the table. And that's where you do these tasks, such as making your lists and making your checklists and things that you need to do and organizing your calendar. Break down those big tasks. So take those larger activities like the laundry into individual tasks, put them on your list separately. So have wash the laundry, dry the laundry, fold the laundry, put it away. Put those each as a separate task because they are kind of a separate task within that big task, but break them down a little bit. Use memory aids. So calendars, lists, apps on your phone that can ding and set alarms on it and tell you when you need to do things, cue cards, anything that will help you be successful and give you those notes that keep you moving. Minimize distractions. This is a difficult one because the recommendation is to focus on one task at a time in a quiet environment. Do that for a while until you get really good at that, and then try to stimulate yourself a little bit because real world environment, you're not going to be able to focus on one task at a time. And part of those troubles that we talked about earlier was not being able to move from that one task to the other task. I kind of struggle with that recommendation a little bit that they have online there. Work backwards. Use the end goal to plan your steps forward. And that's a really good one if you're struggling to figure out what do I do next. So look at what your end goal is. Figure out what all the steps you need to do to get you to that end goal. And that's your list. Those are your steps. Those are your tasks you have to do along the way. And then in this case, when we're saying seek professional help, this is where occupational speech therapy comes in. So either of those therapists would be great to help you try to figure out better ways to manage your time, better ways to organize your day, those strategies for rehabbing that organizational part of your brain. And then kind of along that line, my last O letter for today is overwhelm. Also a very common thing to have happen to somebody that's recovering from a brain injury. It is very common due to sensory overload from lights, sounds, smells, crowds, cognitive issues, emotional changes, cognitive fatigue, again, that comes back in. It's worsened by fatigue. So when somebody's tired, they're very easily overwhelmed by things. And it makes very simple tasks feel like huge feats that lead to shutdowns in the person, lead to emotional outbursts, and it can be very difficult to deal with. So as the person living with the injury, it's important to try to identify those triggers, figure out when you are more heightened, figure out when you get more overwhelmed so that you can ask for help so that you know how to arrange your time, your life, your accommodations for those areas. And as the family member, it's really important to identify when that person's getting triggered and overwhelmed so that you can help to decrease that load for them. So triggers are steps in how to manage the overwhelm, reducing the stimuli. So using noise canceling headphones when you need to, dim the lights, wear the sunglasses, avoid crowds, limit screen time. None of those things are meant to be permanent accommodations. I don't want a patient coming into my office constantly having to wear sunglasses. Over time, we want that to improve. There are different tinted lenses that can be helpful where you don't need those full sunglasses because it's really nice to be able to make eye contact with somebody. So it's really important to get that addressed. Again, the noise canceling headphones can make you more sensitive when you're not wearing them at times. So use them sparingly when you absolutely need to. If you're going someplace that's going to be really loud, wear the noise canceling headphones in that loud situation. Don't wear them at home with the kids all the time because then you're just going to be more desensitized to those kids making noises at home. Pace yourself. So take frequent breaks. Take rest breaks often. And then don't push yourself too hard. Again, this is not meant to be a permanent type of thing. Try to gradually need to take those rest breaks less frequently, but take the breaks before you think you need them. And that was the best piece of advice that my therapists gave me along the way too. Take the breaks before you think you need them, because then you won't need them quite as badly. Simplify the tasks like we've already talked about. Break those tasks into small steps, prioritize them, write out lists and figure out what you absolutely have to do. So when you're making a to-do list, don't put everything under the sun that needs to get done. Start on the top of the things that you have to get done today. Maybe put under that the things that you would like to get done. Those are things that don't necessarily have a deadline. The things that you have to get done, those are the things you need to do first. You learn to prioritize those things that have deadlines and do the want tos, the like tos after that. Learn to say no. This one is a hard one for many, many people, but you have to make sure that you decline those extra responsibilities so that you can manage your current workload and energy. As a person recovering from a brain injury, you don't have the energy to do all the things all the time, and you certainly can't do additional things all the time. So say no, it's okay. You need to reserve your energy for the things that need to get done. Communicate your needs. Communication is huge, and not everybody really is good at this all the time. But you need to be able to explain to friends and family that you need help, what kind of help you need, that you need a quieter environment. Ask for support, not just say, hey, I need help. Say, hey, you know what? I am overwhelmed. I don't know where to start. Can you help me figure out where to start? One of my favorite things is when my adult child came home and he said, Mom, what do you need help with? And I said, I don't know. And he said, okay, let's start here. I said, perfect, let's do it. And I couldn't tell him exactly what I wanted. So I don't like when resources try to say, ask for specific support, because as the person that's trying to heal, sometimes you don't know what you need. You don't know what you don't know. So having somebody else come in and being able to take a look and say, how about we do this? That's perfect. So as that caregiver, as the support people, try to come in and take a look and see where you can help, because sometimes the person with the injury doesn't know how to ask because they don't know what they need. And then the last part of this is structuring your day. So create routines that add structure and reduce decision-making stress, because I don't know about you, but as a person trying to heal from a brain injury, I hate having to make decisions. So anytime you don't have to make decisions, if you have things already written down, you know what you need to do, great, perfect. I often will rely on my kids these days now. I'm like, all right, guys, what do you want for meals? Help me plan the meals for the week. And they'll give me the ideas and I'll just write them down. I don't really have a preference. It's based on what we need to get done and what we have in the house to cook with, essentially. But having that help, and I think that's the biggest thing of all of this with overwhelmed with any of these things, having the help, having the support that you need. Because if you're trying to go through this alone, it's really, really difficult. There are lots of places for support online. I know not everybody has access to online, but if you or the person that you're trying to help has access to online, there are a lot of online supports. So if you don't have that physical person that you can rely on, at least having somebody you can bounce ideas off of and try to help kind of advocate from a distance at times if needed is really important, so that you feel supported in your recovery and that you as a provider feel like the person that you're caring for is getting the help that they need as well. So lots of different things that we can cover related to that. But as we go through this alphabet of ABCs of concussion, again, every topic will have different things that relate back to the person that has a brain injury. So again, you can find information here, whether you're the provider, the caregiver, the person with the injury, if you have suggestions on future episodes. So next letters will be P on moving forward towards the end of the alphabet. So if you have suggestions on topics that you want me to consider, please leave that as a comment on the show. And yeah, thank you for being here, you guys. Let me know if you have suggestions for further conversations. Otherwise, we'll see you next time. And Happy New Year again. Thanks for tuning in to this episode of Brain Wellness, the podcast. If you enjoyed this episode, I encourage you to subscribe, like, leave a comment, and share it so that others can benefit. Please also consider supporting the show by buying me a coffee. The link is in the show notes. You can also go to www.brainwellnesssolutions.com to catch the latest info and get links on all of the social medias there. See you next time.